Welcome to Module 4, Maintenance of the Periodontal Patient. Periodontal maintenance is a continuum of professional care following surgical and non-surgical therapy, and only applies to patients who have undergone periodontal therapy. The term is not used for healthy patients or patients treated for various types of gingivitis. Periodontitis can reoccur without maintenance procedures, and the goal of these procedures is to prevent reoccurrence. Success of periodontal treatment cannot be determined without continuous periodontal maintenance. This is documented in the literature and supports evidence-based dentistry. Take a moment to study this chart. It illustrates the importance of periodontal maintenance. Look carefully at the increase in attachment loss when the procedure is not performed. Periodontitis and perio maintenance go hand in hand when treating chronic recurring diseases. The disease has no cure and cannot be controlled without therapy. This disease is controllable in a vast majority of patients who seek professional care and are compliant with the recommendations of the dentist and dental hygienist. The objectives for periodontal maintenance is the control of tissue inflammation caused by etiological factors, professional removal of biofilm and calculus, the correction of faulty restorative dentistry, the elimination of smoking, and the control of systemic conditions as diabetes aids in the control of periodontal disease and the success of periodontal treatment. Stabilizing and preserving the attached level and alveolar bone levels is the goal of periodontal maintenance. Maintaining the dentition throughout a lifetime is the long-term goals of periodontal care. Take a moment to study this concept map of the procedures involved in periodontal therapy. Periodontal assessment is followed by non-surgical therapy and re-evaluation. If disease is uncontrolled by non-invasive treatment, options to care are assessed. Periodontal maintenance remains the procedure of choice in monitoring periodontal disease. Periodontal maintenance is a team effort between the patient and the hygienist. Patients must maintain meticulous self-care and adhere to recommendations of periodontal care schedules. The dental hygienist must provide high-quality professional care that promotes proper periodontal maintenance at care intervals and reviews patient motivations through instruction in self-care techniques. This will eliminate or reduce the risk of periodontal disease reoccurring. How does periodontal maintenance differ from regular patient treatment appointments? This question is asked often by patients and must be addressed with a clear and educated answer. As clinicians, we must assess the social history, dental status, medical status, current medications, and updated dental care in preparation to address this question with patients. They must understand their role in periodontal maintenance as well as ours. The patient's perception of self-care efforts or issues play a major role in the success of treatment. Educating them will only mean the development of compliance throughout each appointment. Clinical exams during periodontal maintenance appointments include thorough clinical assessment. These procedures are required at every appointment. Results are compared with baseline clinical data gathered during periodontal probing procedures, oral health assessments, and radiographic exposures. Steps in periodontal maintenance examinations include the following: intraoral and extraoral examination, dental materials examination, radiographic examination, periodontal examination, evaluation of effectiveness of patient self-care, identification of treatment needs, periodontal instrumentation, patient counseling, and the application of fluorides. The periodontal maintenance examination includes the following procedures that must be performed at each and every appointment and documented in the patient chart. Probing depths with progressions noted at 2 mm increases, bleeding on probing with visibility within 10 seconds after gentle probing. These sites are charted and require more attention with instrumentation. Attachment levels with progressions noted at 2 mm increases and compared to prior documentation. Tooth mobility noted to identify stability or increase in mobility. Furcation involvement, mucogingival involvements, and gingival plaque levels. The self-care evaluation must be performed at each and every appointment and documented in the patient's record. This includes the following procedures: plaque scores to reveal the patient's level of self-care, documentation to record the patient's motivation to sustain good self-care. The hygienist must be a cheerleader for oral care as they simplify regimens for better compliance and suggest alternative techniques for improvement, and the assessment of the patient's progress and performance. It is important to inform the patient of their assessment. Failure to inform or motivate a patient may be perceived as disinterest and therefore have a negative impact on the future maintenance procedures. The periodontal instrumentation must be performed at each and every appointment and documented in the patient's chart. This includes the following procedures: thorough plaque, biofilm, and calculus removal, the attention to the conservation of root surfaces during periodontal instrumentation, and the utilization of only the best instruments suited for the job, as ultrasonics, precision tips that are designed to create the least amount of damage on root surfaces, and curettes. Plastic curettes are also effective for deplaquing of areas. Patient counseling should be performed in such a manner that an interest in the betterment of the patient is clearly expressed. Failure to provide information may be perceived as a disinterest. Most all patients need reinforcement and motivation, especially when addressing smoke cessation, risk factors associated with comb care, medications or social habits, and nutritional counseling. The routine application of fluoride is necessary to promote remineralization and prevent root caries. The control of dental sensitivity created from over-instrumentation and the possible antimicrobial properties to decrease plaque biofilm is one of the added benefits for fluoride applications. Patients treated for mild chronic periodontitis and moderate chronic periodontitis are required to alternate visits between the general practitioner and the periodontist. Severe chronic and aggressive periodontitis patients should be maintained in a periodontal practice. Frequency of visits are individualized for the patient during periodontal maintenance intervals. 3 months is most common in the removal of subgingival pathogens. These levels rise in the 9th to 10th week post-treatment. Less attachment loss and tooth loss with shorter intervals is documented in the literature and supports evidence-based dentistry. Determining factors for interval maintenance appointments are determined by the following: severity of disease, patient self-care effectiveness, and the host response from systemic or genetic factors, which would shorten the interval for the diabetic or autoimmune patients and smoker. Identifying retreatment causes must include the assessment of self-care habits, maintenance intervals, instrumentation, and systemic factors. Treatment options can include localized instrumentation, localized antimicrobial agents administered, and localized or generalized surgical procedures. Patients treated successfully for periodontitis and disease tends to reoccur will present with additional attachment loss, either generalized or site-specific. The most common sites is in furcation areas, where clinical signs for reoccurrence of periodontal disease is progressive attachment loss, deepening pockets, bleeding upon probing, presence of exudate, radiographic evidence, and the increase of tooth mobility. Reasons for reoccurrence may include inadequate self-care, inadequate scaling and root planing, failure to control systemic factors, occlusal trauma, inappropriate surgical techniques, treatment performed under poor prognosis, and refractory periodontitis presented that resists treatment. Referring patients to a periodontist is a recommended procedure. Patient compliance behaviors coincide with medical and health advice. Some patients faithfully adhere to recommendations and follow the strict programs of maintenance intervals given to them. The chart illustrates the recommended guidelines for non-surgical care of periodontal patients. Take a moment to read this chart thoroughly. The non-compliant patient must be approached differently, as motivation is a different process for each patient. Reasons for noncompliance may be fear of dental treatment, expensive dental treatment, low priority, contemplating demands on patients' time and financial resources, denies they have a problem, failure to understand the severity or the implications of noncompliance, and perceives the indifference of the dental healthcare worker. To improve patient compliance, provide printed self-care instructions and simplify your recommendations by limiting self-care aids. Seek out patient concerns and accommodate their needs by informing and counseling them on the specifics of their disease. Monitor missed appointments and provide positive feedback when possible. Identify areas of improvement, compliment them in front of the dentist. Use positive reinforcement to convey a motivational message and limit criticism. Remember to be truthful on their condition at all times, even though you are providing them feedback. Take a moment to review this concept map. There are many steps in improving patient compliance. Understanding the strategies and approaching the patient in a proper manner will be steps to successful implementation. Varying your approach as needed and provide positive feedback by complimenting your patient. Provide the patient with printed material and simplify the self-care process by eliminating the number of aids and consider alternatives to floss if you are noticing a lack of compliance. Allow for open-ended questioning during your discussions and seek out what concerns your patient. Remember to send reminders for upcoming appointments and follow up on any missed appointment. This will help to maintain periodontal intervals as necessary. Common problems with periodontal maintenance patients are related to age. 50% of the patients who are affected by periodontal disease are 50 years of age and older, and 70% are 60 years of age and older. Occurrence is determined by attachment loss, inadequate oral hygiene, carcinogenic diets, infrequent dental visits, past caries experiences, inadequate saliva flow, lack of fluoride exposure, and removable partial dentures. During caries detection examinations for periodontally involved patients, it is important to assess exposed root surfaces due to attachment loss. Shallow, softened areas on the root surface may appear leather-like in consistency. Newer lesions appear yellow to light brown, while older lesions appear brown to black. The location may be at or slightly coronal to the free gingival margin and spread laterally and around the tooth surface. No specific organism has been identified as the cause of root caries, therefore the etiology is unknown. A mix of bacterial populations are known causes, with demineralization occurring at a pH of 6.2 to 6.7. Root surfaces are more vulnerable than enamel, and mineral loss is 2.5 times greater than at enamel. In the prevention of root caries caused by periodontitis, remineralization is necessary. Fluoridated drinking water, the use of home fluorides, and the application of professional fluorides are all recommended treatment options for remineralization. Antimicrobial rinses and supplemental therapies for periodontal maintenance is prescribed on an as-needed basis. Chlorhexidine is an antiseptic and antimicrobial oral rinse. It provides protection against a wide range of bacteria. It kills bacteria by binding to cell walls. The FDA approved chlorhexidine in 1986, and to date, chlorhexidine glutamate is available in 12% concentrations as an oral rinse solution. Xylitol is a naturally occurring substance. Manufacturers of xylitol market it as a derivative of xylem, which is found in the fibers of many plants, including berries, oats, beets, sugarcane, and birch. Commercially available xylitol is produced by the industrialized process of hydrogenation. There is currently no literature on any detrimental effect of consuming hydrogenated sugar, and it is important to note that hydrogenated fats and oils were used for many years before varying damage effects of health became widely known. Given the violent industrialized process that is required to produce a hydrogenated sugar like xylitol, it would seem wise to avoid its base on the very poor track record of hydrogenated foods. Phosphopeptides have been proposed to have anti-carcinogenic properties and are produced by the tryptic digest of milk proteins. It readily binds with saliva, pellicle, plaque, soft tissue, and even the hydroxy component of enamel, and maintains saturation levels of minerals, especially calcium and phosphate, at the tooth surface, depressing demineralization and enhancing remineralization. It is highly effective in treating active caries prevention in patients susceptible to dental caries. Caries risk management is not a common practice for periodontal patients. Due to the nature of the pH of the oral cavity, most periodontal patients do not experience high levels of caries. If the periodontal patient presents as a caries risk, assessing their medication and diet will be necessary. Pathological factors, including acidogenic bacteria, salivary dysfunction, and dietary carbohydrates, are related to caries progression. Protective factors, which include antibacterial, salivary, calcium, phosphate and proteins, salivary flow, and fluoride in the saliva, can balance, prevent, and reverse dental caries through a process of remineralization. Remineralization is a natural and reliable repair mechanism for non-cavitated carious lesions. If pathological factors prevail, caries progression. If protective factors prevail, the caries process is halted or reversed. This week's discussion board topic will be of your own choosing from case studies 2 or 3 on page 572 in your textbook. Post your response to the discussion board with a 100-word posting by Wednesday midnight, and respond to one of your peers' discussion postings with a 100-word response by Sunday midnight. Make sure to respond to a peer's posting that is unlike your own. Complete the 15-minute Module 3 quiz, and this concludes the audio lecture for the week.